Welcome everyone to Symposium 23, the Years in Review. We took a slightly different spin on Years in Review this year, so hopefully you find it informative, and we're glad that you came to the session. I want to start out with a housekeeping thing. There is a way to submit questions in the app, which is very difficult to figure out. If you go to the schedule for the day and then you go to the Symposium 23 topic, if you go into the main one, not any of the individual talks, the main one will have a Q&A spot at the bottom. If you want to submit your questions, your Qs, during the talk, you can do it there in the app and we'll read them out. If you would prefer, there's also a microphone for questions for 5 minutes after the speakers are finished. And I wanted to say welcome on behalf of myself, Kathy Ramos, and Erica Resch, who is our co-chair today. I'm going to show our presentation disclaimer for all of NACFC, and then my disclosures here and Erica's. And here are the list of speakers for today. We're going to hear about the CF Learning Network, the CF Lung Transplant Consortium, the Success with Therapies Research Consortium, and then the update in pain and review of the recent pain guidelines. So we're really looking forward to all of these speakers. And then finally, just a quick touch on the objectives. We want to describe the activities of these several CFF-funded networks and consortia and explain the CFF guidelines process. So I'll hand it over to you.
So with that, we'd like to invite our first speaker up, Theda Ong. She's a professor of pediatric pulmonary and sleep medicine and the center director at Seattle Children's Hospital. She's also the leadership team chair for the CFLN, and she's going to talk to us today about advancing quality through the CFLN.
Thank you so much. Can everyone hear me okay in the back? Great. Thank you so much. It is an absolute pleasure to be here today with all of you and share with you a glimpse of the excitement that's going on in the Learning Network. We are just thrilled to just share our progress here and come along for the ride. So here we go. Ooh, I got to do the arrows. Okay. All right. I do get some support from the Cystic Fibrosis Foundation, of which I'm very grateful. To begin us off today, I'm going to start with an outline. We're going to start with talking about the origins of the CF Learning Network and how we're founded in principles of a learning health system. Then I'm going to talk to you about the people who make it happen, how we're engaged and organized to shape and lead this work together as interest holders of patients and families and care teams together in this space. Then I'm going to highlight some really published, recent, organized, multi-site data-driven improvements just to help showcase the kind of work and give you some tangible examples of what's going down. And then a brief word I'll end on in terms of the spread of innovations and opportunities within your own sites to jumpstart improvement. All right, let's get started. We are in a time. Things are changing so fast. There is an aging population. This graph shows from the CF registry from 2024, the explosion of people over the age of 50 with CF from 350 in 2004 to now just 2 decades later, over 3,000. More and more people are eligible for modulators, and that red part in the middle are people who are using elexacaftor, tezacaftor, ivacaftor, going from 20% to 76%. But there are still 2,400 people who are ineligible for those kind of therapies, really demonstrating that what we need are really flexible, personalized care opportunities. How do we know that this is happening? There's also major milestones happening in the lifespan of people with CF. 650 pregnancies going on in our community. And care model changes. Over 11,000 telehealth visits that have been reported in the last year. So how do we keep pace with all of these care changes that are going on right now? How do we learn? How do we learn together? And that's where the approach of a learning health network comes in. A learning health network is where patients, families, clinicians, researchers, we co-produce together. We're trying to produce measurably improved outcomes. And the crux of this is a learning cycle that integrates practice, data, evidence all together. And what it does is it brings together patients and families deliberately into the learning process. What's happening at the point of care? How do we learn from that? Where do we take that data and systematically gather it, help us create our evidence, put forward the research that's needed, that we're coming from all kinds of sources, that really makes us produce evidence that is the most promising, that we can then put that and translate back into practice and keep learning from it, really to produce those measurable outcomes together. So this is where the CF Learning Network, starting in 2016, the CF Foundation said, how do we get on top of this concept? So they partnered with a team at the Anderson Center at Cincinnati Children's Medical Center. And then in those early days, and many of you in this room were there, remember we were like, what are we doing here? We got getting together. We weren't quite sure why we were there, but we started to pick up some momentum. We started to feel when we were part of a community coming together, again, as people with CF, as families, as researchers, as clinicians, we're like, what are we doing here together? And right in the middle, as we feel like we were hitting our stride, the pandemic. And this was a real opportunity for us, an opportunity for us to say, how are we going to rapidly organize? We're already here. Can we learn how to adopt telehealth practices into the care model? And I'll talk a little bit more about this in the future. And since that time, have really hit our stride. We grew to 37 programs, and the network facilitation transitioned to a team at the CF Foundation. And now looking forward in 2026, we have 40 programs engaged, 17 adult, 23 pediatric, representing over 7,000 people with CF. I'd like to tell you the experience of the CFLN in my own words, but it actually doesn't resonate as much. And luckily, I don't have to, because work by Erica Van Sitters, who led a mixed method study, can tell you the experience of the CF Learning Network participants at that time in their own words. And 4 key tenets really came up in terms of what are some attributes that really resonate as the experience of coming together as a CF Learning Network. One of them is the leadership structure, and I'll give some more details about this going forward. But there's a triad leadership. And a triad leadership is having patient and family partners elevated as leaders, QI experts elevated as leaders, and physicians elevated as leaders, and giving them an opportunity to grow in their own skills together. There's also this culture of co-production, where patient and family partners are not just advisors, but designers and leaders. So we're doing a double duty, triple duty. Many, many things that they're juggling. There is also active practice in that being able to participate in quality improvement in such an organized way teaches you the skills, practices the skills in real time. So when you're working on a project, graduates us up to a higher level of care. And all of this forms a learning community that provides a space for teams to connect and communicate about their innovations together. It's exciting. All right, let me tell you a little bit about the engagement of our interest holders. The All Network together is governed by a network leadership team. These individuals are incredible. We get together in these meetings, we share ideas, every perspective. And with my co-leaders, co-chairs, Melanie Lawrence, who is online, maybe listening to some recording somewhere, I am so grateful for what she brings to the table every day that we get to meet. And Kristen Nowak here, another co-chair as a quality improvement leader, we replicate that triad in the network leadership team as chairs and work so closely with all of these perspectives across the network leadership team members. And then together, our goal is to set our network aims and steward the strategic direction to achieve measured results. We also work closely with peer work groups. And again, peer work groups are a place where there's provider leaders, quality improvement leaders, and patient and family leaders. And these work groups are there to share approaches to local and the network-wide efforts for team building, and provides a forum for listening to really connect and bring all those ideas together in the community. Within individual programs, there's also an expectation for this ongoing triad leadership. Again, same names are coming up. You have quality improvement leaders, a patient and family partner, and physician and advanced practice leaders together that help support the program team. And their job is to lead their local team in applying those QI methods, using data to drive tests of change and measure impact, and also practice co-production to partner in these systems of care. One thing that we have learned in this practice, and I'll highlight work here led by Brett Gamble, the former parent and partner chair of the network leadership team, is how do we learn how to co-produce? This is really the special sauce together in all of these teams. And I'll refer you to this work in BMJ Open Quality that has lessons on how care teams can foster this really important aspect of working together to really co-produce changes. And I'm not going to go into all of these things in terms of time, but really it's about promoting these inclusive and safe spaces to communicate. Having operations to work together so you have shared working documents. You train everyone with all the same methods, including HIPAA training. I'll say that out loud. There's financial recognition for these efforts, and then also this emphasis of open access to evidence, because we all need to access the same materials to make decisions about them, to look at it. So we have a real commitment to making sure that the evidence that we are publishing is available for everyone. Critical piece of the CF Learning Network is our operations support. And this is a huge shout out to Kathy Sabadosa and our operations team. Thank you. That really help facilitate the network operations and learning seamlessly across all of these sites. These are a few of the things that they do in these bullets, but there is so much more that help facilitate all of this that goes down. There is also a critical University of Virginia data core who is there to operationalize the network and learning workstream data collection and reporting, led by Dana Albin and Beth Horton in this project, to really help organize and present the results back in real time so we can share in that learning and interpret together. Okay, let's get some tangible examples of what this looks like. I'm going to start by giving you a high-level overview of what is an innovation lab. An innovation lab is this systematic approach for how we're bringing all of our teams together to apply these QI methods. It starts with a design phase where we bring together clinic content experts, subject matter experts, all together so that there's a scope and the aim that's set forward, and we're like, this is what we're going to do. Then, in order to facilitate and execute, there needs to be a call for interest. So programs aren't forced to sign up. They have to say, I have the bandwidth. I can do this. I'm going to participate. And they go through a series of decision-making on their local teams. And then they decide, okay, I'm going to do this. This is of interest to our team together. And then we sign up for lab huddles. And these are super fun because this is where we get to do the spicy plan, do, study, act cycles, or failure modes, effects analysis, or process mapping, all kinds of things that make us sing to really organize that learning and put it all together. Testing, sharing our ideas consistently across the time period of facilitating these labs together, and then putting all that data back with the amazing work of the data core and having that data collection and displays organized for us so we can continue to decide, are we making it back to reliable processes of care? And are we ready to then elevate those learning and plan the spreading to more places? And then we have a real commitment to spreading and sustaining. We have writing groups with very inclusive authorship for everyone who is able to participate in those efforts, including patient and family partners, which is a really important part of who is part of the design team of those efforts. As a whole, we have a publication committee that supports these processes together. And then we also have change packages. Change packages are where we have this collection of ideas together. We need to be able to share, not just within the learning network, but beyond. And that's what those are. So, talk to you a little bit about what happened in the pandemic. And I'll call out work here again by Dana Albin and then our physician co-chair at that time, in that unprecedented time in the pandemic. And 29 sites at that time said, wow, we really need to figure out how to learn. How do we do this real-time shift to virtual care? Can we do what we expect? What is the best care possible for people with CF? One of those is, can we do multidisciplinary care? So for every 8,200 clinic visits, yes, over 85% of our participating sites had access to multiple CF care team disciplines at that time. And that opportunity to really understand What are the agendas? What matters to you in those points of care? 92% of those visits shared agendas with people with CF, had that process in place. So this tells us, okay, we did telehealth through the pandemic. We can do it, but there's more learning to be had. And again, in work published this year, and the CF Foundation Registry Analysis was looking at what are the outcomes of telehealth use and thinking about people who participated in the learning network programs in that lab, as well as the care center network. Those who weren't participating in the lab and those who were in the learning network but did not participate in the lab, were too constrained at that moment in time, because it was a constraining time. And what we found was, yes, there were more telehealth visits, as shown here in the blue bar on the left, of telehealth iLab participants overall, compared to the orange bar, which is the non-telehealth iLab participants. But the gray bar demonstrates those care center network. And even if you were not part of the network, as expected, you were doing a lot of telehealth. And that's a really important concept, because it helps us all learn together to say, yes, we could find factors for what was not likely to be factors of what made it hard to participate in telehealth, but also what made it likely to participate in telehealth and have all of that great learning together. And more importantly, understanding that there was really comparable nutrition and lung function outcomes for everybody doing telehealth, for whether you're in a CFLN program or a non-CFLN program, which really makes us a viable model for flexible care that we need in our shifting care landscape now. I'm going to shift now and talk about modulator screening. And then this is work that I want to highlight from Kevin Lonabaugh and Rachel Linneman. There was a push to say, okay, do we know our patients are using modulators? So in this lab, in its initial phase, had 23 sites sign up and say, yes, we can establish routine screening. So over 80%, I think 90% actually of sites started screening for modulator use. Are you using your modulator? And the number one reason for why people deferred use for modulators was related to prior side effects. This is a Pareto chart here on the left that's based on the frequency of how often you would see some of this. Well, this is a really important concept. So this made us shift to say, what practice do we need right now that families and people with CF are dealing with? Well, one of those concepts, critically, is that, are you having side effects? So we need a process now to screen reliably for, are you having side effects? And so again, 21 sites signed up for phase 2 of a modulator lab. And again, almost everyone in those sites established a reliable process for screening. And in there, we discovered 1 in 4 people with CF had symptoms associated with modulator use. And this becomes really important, because now we really need to think back about what's that treatment decision-making that's happening at the point of care. What practices do we need? How many other people need to make sure they're asking the questions, how are you feeling with modulators? And that helps inform long-term treatment decisions. All of this is not that I can share today, but it's published, open access, as I mentioned before, in pediatric pulmonology, and in a change package of those ideas that worked, in addition to our QI workbook that is hosted on the CF Foundation Resource Library. I also want to call out a couple of other abstracts that are here at NACFC. I encourage you to go to their poster numbers, where you can learn more about the data system that's developed by the UVA Data Corps, poster 849, and the CFLN Innovation Lab that was screening for anxiety and depression, led by Zoe Orcutt and Danielle Gotts, in poster 548. Okay, brief word about the spread of innovations to jumpstart improvement at your own sites. So just as a big snapshot of where we're at right now in the CF Learning Network. 40 programs, over 7,000 people with CF across the US. We, since our inception, have had 14 innovation labs done. 7 core publications, 4 change packages accessible for you with all of those ideas that we've already tested. And just as the excitement and the momentum, 60 abstracts that have been submitted just in 2025 to NACFC from all of our programs, ready to share all of the incredible QI work that is happening at their local sites. Really just a testament of the momentum that we have within the learning network to be this productive space. But it's not just about the CF Learning Network. it's about everyone else also, beyond the care center network and beyond as well. And there are opportunities, whether you're a clinician, whether you're a patient or family, everyone is welcome to participate. No prior QI experience needed. And this is important because you all have access to these. And these are sessions that are focused on pre-transplant care, but also step-by-step QI projects that can be supported in here. And the experts in the Learning Network are here to also help. Here's another one in terms of QI fundamentals, also there, and you can learn more about them or sign up through these QR codes. I see someone taking a picture, so I'm taking a minute. Okay, so in summary, the CF Learning Network is a learning health system organized to engage interdisciplinary members alongside patient and family partners as leaders and designers, to approach data-driven learning with systematic quality improvement methods, and to share and spread QI methods, best practices, and adapted tools committed to advancing quality care for all people with CF. I really want to acknowledge the CF Foundation, the CFLN operations team, and all of the teams that are participating in the Learning Network. Thank you all so much for your time. Appreciate it.
So if anyone has a question, you can submit through the app or feel free to come up to the microphone. I'll start us off. I feel like the CFLN's done a lot of diverse work in a lot of different areas. Can you speak a little bit about how you choose which topics you're going to do innovation labs on?
It's a really great question that I think has evolved over time, but there is a lot of effort with regards to, I want to say the strategic planning that involves engaging with the community, getting back to say, here are some priorities, and there's feedback back and forth across these data streams. So with the operations team, with the network leadership team, and then broadly through the work groups and then beyond. And then there's lots of meetings and feedback that is trying to really distill up that. We're also, there's so much work across the community as a whole to try to identify what some of the priorities matter across the community and aligning all of those things together to help set what that strategic plan ultimately is.
And then can you talk a little bit about what's coming up next for the CFLN?
So there is some active work streams right now. There is work toward understanding about, so we have the Mental Health Innovation Lab that is right now actively screening, but it's more connecting to what some of those outcomes are, and are we providing some of those resources similarly. And then I'll also say the health-related social needs, that is another area of active progress going forward. And then there's additional projects that are working with remote sampling that will kind of explore, can remote sampling start to be a place in an area of further discovery. And similarly, thinking about how we approach just and equitable outcomes for all people with CF. So as we're doing quality improvement, are we measuring in a way that helps us understand if we are inadvertently widening disparities with our interventions?
Thanks, Theda. Joe Paluski from Pittsburgh. That was a great talk. I wondered what the barriers are to more centers participating. And related to that, I could imagine time commitment is the biggest thing. Could you give us an idea of what the cadence and time commitment look like?
I think we've really evolved over time. I'm trying to learn, what's the right size or fit. I think we want as many people to have that. So many sites are doing quality improvement work without being part of the learning network per se, and that should not be discounted in any way. And it's, I think for really being productive in the learning network, there's so many constraints, especially now. And we are funded by a grant, currently, so I think that has to be part of the thought process, but also making sure that we have a critical mass of teams that represents and has those places. And the requirements to be a learning network site really include having that high QI capability, having the patients and family partners really part of your team. We meet weekly on my team, as an example, with our patient and family partners. We just onboarded a new person here today. So, we're really fortunate. But again, all of these requirements that are part of being part of that site, I think just thinking, and I'm sure there may be opportunities going forward as, we try to see who can participate and keep the mission of it going.
One last quick question.
Mainly a comment. Thanks for sharing our story, Theda. For any teams, co-production is the secret sauce. And for any teams that want to do high quality QI, Brett Gamble's first author paper, Theda's senior author paper, if I recall it, the appendix has 50 to 60 pages of roadmap of how to do co-production with patient and family partners. I can't overemphasize how good it is. So they did just outstanding work.
Thanks, everybody.
Thank you.
Next, we're going to invite Dr. Joe Paluski up to the podium. He's a professor of medicine and the CF Center co-director at University of Pittsburgh, and he is the co-executive director of the CF Foundation Advanced Lung Disease Initiative and CF Lung Transplant Consortium.
Thanks, Kathy and Erica, for the opportunity to be here. Kathy asked me to do almost something impossible, which is to cover a lot in 20 minutes. So I'm going to do my best, and if it seems like a smorgasbord, I apologize up front. Maybe we'll have time for questions in the discussion period. So what I'd like to do today is talk about sort of what we learned about the trajectory of advanced lung disease with and without highly effective modulator, and propose the concept that we sort of have two populations of people with advanced lung disease. I think we live this in practice, but maybe it helps to formalize that thinking. Lung transplant referral remains a challenge for us, and we'll talk about that. And then I want to introduce the CF Lung Transplant Consortium and the approaches the consortium's taking to try and improve lung transplant outcomes. So thanks to the work of many of you and the support of the CF Foundation, when we created the Advanced Lung Disease and CF Lung Transplant Initiative, we created an Advanced Lung Disease Registry. And thanks to the registry coordinators in the room, we've grown this registry over time, in part because of improved survival. We had 2,000 participants in 2020 and 2,500 in 2024. The median age has increased as people have, of course, lived longer with modulators, but you see a wide range of ages there, all the way from teenagers through those who are greater than 70 years old. So this data entry has been very helpful to give us an idea of the granular detail that happens and look longitudinally at the outcomes of people with advanced lung disease, which, as a reminder, at the time of enrollment, they have FEV1 under 40% predicted or other comorbidities that predict a shortened survival. What this registry data has demonstrated is that there's a significant improvement in FEV1 in many of these individuals. So these were enrolled at FEV1 under 40, and this histogram shows the 2024 report looking at the FEV1 distribution by age. And you see that there's a large population of people who are now green, FEV1 greater than 40%, when they were under 40% at the time they enrolled in the registry. Other registry data, such as the French Compassionate Use Registry for the use of ETI, show a significant improvement in lung function. On the left-hand panel, they look at all patients, the improvement in FEV1. So this, again, was a population of very severe disease, FEV1 30% predicted on average. And within a month of starting ETI, they went to 45% predicted, and that was relatively stable over time. If you look by age group, it's that improvement was enjoyed across a variety of age groups, maybe with a trend towards lesser improvement in those greater than the age of 38. More recently, Liz Cromwell and her team at the CF Foundation looked at the registry of those with advanced lung disease and created a trajectory of lung function change going back 400 days before the initiation of ETI at time zero through 1,000 days, or basically 2.7 years after the initiation of ETI, and had a control population, of course, the people with advanced lung disease not on modulator. You'd see this big shift in the intercept that occurs when people go on ETI of 8.45% predicted FEV1, whereas those without ETI have a progression over time. And you see the slope in the changes over on a per year basis, where those on ETI are fairly stable, very stable, and those without ETI have a minus 1.89% predicted drop in FEV1 per year. So we have two groups here essentially, right? You have populations that look on whole to be stable and another group that does poorly. When we're thinking about survival, when we think about transplant, our job is to prolong survival, increase opportunities for lung transplant. So if you look at the survival with severe CF lung diseases in the pre-modulator era, work by Kathy Ramos and her colleagues showed that those with advanced lung disease have an unpredictable survival. It's highly variable. It's surprisingly 6.6 years median compared to a little over 2 years in historical data going back to the 90s. But importantly, about 10% of those individuals died per year without a lung transplant. This led us to believe that we have a real access to lung transplant problem, and is part of what propelled us to move forward with this lung transplant initiative. If we look in the other end of the spectrum, those who get a lung transplant, how do they do? It's important to put this in context when we're talking about trying to prolong survival. So the median survival for individuals with CF in most registries is about 10 years. For cystic fibrosis. And those were transplants done in an older era, going back all the way to 1992 through 2017. If you look more recently at data published by Miriam Valpour from the Society of Transplant Surgeon Registry, you see 70% 5-year survival for those with cystic fibrosis who are in yellow. And note that that survival is better than it is for other indications for lung transplant. So it always begs the question, how do we predict survival in people with advanced lung disease? And we know from the pre-modulator era that these comorbidities are generally associated with worse outcome, that is a shortened survival. And I won't read all of them, but the things that we can measure here and collect on time, things like oxygen, carbon dioxide, 6-minute walk, heart association class, presence or absence of pulmonary hypertension, and its severity. So the advanced lung disease guidelines use these predictors to say, let's, in this cohort, try and collect this data over time so that we can learn how well they predict outcomes in people with and without modulator. We don't really know, and that's why we're doing this study, to try and determine people who are on modulator, what are the risk factors for shortened survival, and what is the magnitude of the risk factors. We know that many people on modulator with advanced lung disease can stay on oxygen and live for many years. I have people with FEV1 of 20% predicted on 5 liters of oxygen who are stable for 6 years. That's an important population. They're prolonging life without transplant. We want to see that, but we also don't want to take risk and have them not get the opportunity for transplant. So the guidelines were published in 2019 with Kathy as the lead author, and the highlights are really here. We want to normalize the conversation about lung transplant, introduce it early as a therapeutic option, certainly starting at FEV1 50% predicted. We want referral based on disease severity. So those with more severe disease, such as those with FEV1 under 30% predicted, we think that everybody in that bucket should be referred to give them the opportunity. The evaluation can be tailored to disease severity. So somebody who you don't think is at imminent risk, but you want them to get education, they can get a limited evaluation by the transplant program so that they become familiar with the process. And then there's multiple steps to this. There's referral, evaluation, listing, transplant, and then post-transplant care. We don't think that a referral is going to lead to all of those things. In fact, many times we don't know, and we know there's going to be this deferral. It's okay to have a long lag between the time somebody's referred and the time they actually get a lung transplant. And then lastly, one of the real key points is that CF programs shouldn't try and determine transplant candidacy on their own. We've seen a number of patients who've come to us as self-referrals, people who were told by their local CF center they weren't a lung transplant candidate, and after education and some remediation of some issues, they became transplant candidates. So how are we doing across the network with this concept of referring for lung transplant? We have progress to make here. We're not doing great. So this registry data looks at those who were referred for transplant in light blue, those who were not referred but at least had a discussion in dark blue, and those who were not referred and had no discussion. And disappointingly, there are about 40% of individuals who have FEV1 under 30% predicted who have still not been referred for transplant. You can say, well, it's about 160, 70 people, but that's a group of people who are at risk and really should get an evaluation. We do a little bit better at the older ages, older FEV1s or higher FEV1s for some of these things like discussion. But the bottom line is we really need to be doing testing. We need to be looking out to see who has severe disease and stratify their risk as best we can and make a referral and certainly have the discussions and ideally make a referral. So what's the testing? Echocardiogram, 6-minute walk, blood gas. Those are only being done in 20-25% of people in the advanced lung disease registry, and only 40% have had one of those tests. 20-25% have had all three. So we have a lot of room and progress to make there to collect the data so that we can learn and identify disease severity. So you may ask, why aren't people referred? And the registry collects this information. It varies from clinical stability in the vast majority. So over 60% were for clinical stability. Patients declined 20% of the time. And then there were a hodgepodge of other reasons: adherence, substance use, limited social support, poor nutrition, mental health, microbiology, and insurance. And I wanted to spend a few minutes to talk about each one of these issues. One is the patient declined. Why did the patient decline? I think that's a really important question. The quality of the discussions that we have with people with advanced lung disease are really important. A lot of our patients have incredible courage and live with a semi-state of denial that they're sick. And that denial is great. It keeps them going, allows them to do things that we don't think they should be able to do. But in reality, it prohibits them from moving on to the potential next step of what are they going to do when their disease progresses. So shared decision-making regarding transplant and end of life is important with deliberate conversation. Take a look at the poster number 634 by Fassbender et al. That looks at the qualitative aspects of those discussions. Focus on eliciting goals. That's really what it's all about. We want to know what the person's goal is. If their goal is prolongation of life and living long, then they need to face the reality in many cases that without a transplant, they're not going to live a normal lifespan if they have severe lung disease when they're in their 20s, 30s, and 40s. I like to present transplant as a safety net. So it's not like something you need now. It's something you may need to consider in the future. So think about it, get the education, and know that that safety net exists or doesn't, because it'll help you in your life planning. And then we have a tendency, I think, to think we know more than we know. And we also have a tendency to rely on anecdotal experiences. So we bring some element of bias sometimes to these discussions based on previous experiences. And it colors our conversation. So it's important to avoid a lot of speculation. We want to educate people, but we don't want to bias them and project the outcome of a transplant education and transplant referral process. Social and financial support are often remediable. These aren't hard stops for many people. There are a lot of resources through the CF Foundation and local charitable organizations to allow people to overcome that. I mentioned education. There are a lot of tools that are out there. I would recommend that you have your care teams use these. If you haven't already, cff.org has a wonderful website on the lung transplant process and outcomes. UNOS.org has a number of materials. And then Kathy's worked really hard the last couple of years on a research project and developed a web program to allow people specifically with CF to make informed decisions about transplant. It's called Take on Transplant. Look for that to be available sometime in the next year. And importantly, transplant programs do a lot of education. It's not just about the medical stuff. They do a lot of education with patients and families to allow them to make informed decisions when the time comes for transplant. In the spirit of the CF Learning Network, Theda knows this, the Learning Network took on lung transplant readiness in people with CF as one of their projects. The group at the bottom, I won't list all the names, did a wonderful job of walking through the first parts of this process. So remember, the first part of the transplant journey is initiating the conversation and making a transplant referral. So appropriately, they focused their attention to those parts of the process. And I won't read all of this for the sake of time, but there are a number of recommendations and a large number of tools that were developed to ready your staff, get them educated on the process, track advanced lung disease, initiate the referral discussion, and how that can be done sensitively and with patient preferences in mind. And then another set of recommendations and guidelines about how to make the actual referral, so the nuts and bolts of who to contact and how to contact. It's important to do this early, and I just want to sort of emphasize that. And this is a wonderful program and resource. And then Theda mentioned the Quality Improvement Training Series, the pre-transplant shared care is in January, and following behind that is a post-transplant shared care. I'm not going to talk about that today, but it's also an important opportunity. So QR code will get you the information and allow you to participate in these. And then lastly, a plug for PEP skills. These are some of the hardest conversations we have with patients when you talk about end of life and lung transplant. And the things that are learned through the PEP program can really allow us to do best at building trust, creating open dialogue, and setting goals by partnering with patients and families so that we help them to make the right decisions. All right, how about adherence issues? This is something that varies by transplant program, but my experience is that past performance doesn't always predict the future. You have people who have real adherence problems, but when they get sick and are looking at their mortality, they can remake themselves if you give them the opportunity and coach them. Transplant program policies vary widely on the use of some of the things that are perceived as barriers, narcotics for pain, marijuana in various forms, not an absolute deal breaker at many programs. There are some absolute contraindications that I've listed there. How about microbiological barriers? This is another reason why people sometimes don't refer for transplant. There are controversial pathogens with literature suggesting that patients with these pathogens have worse outcomes. And while that data is true, in many cases, it doesn't predict a 0% survival. It predicts a 50 or 60% survival. And sometimes taking risk in the face of bad pathogens is the right thing to do for a fully consented person. Transplant programs vary in terms of risk aversion. And there's a tendency in transplant programs and infectious disease specialists to focus on a clinical response to antimicrobials, not on the antibiogram. It's been hard to get that changed, but we're working on it. And then novel therapeutics are being developed for some pathogens, bacteriophages and newer antifungals. So I'll give you one example. Burkholderia sinusopacia has been seen as a deal breaker for lung transplant in the US and most sites in Canada. We looked at our retrospective experience going back from 2007 to 2019. The actual survival for the later cohort of those in the newer antibiotic era, that means fixed combination beta-lactam and carbapenem inhibitors, was 55%, which is about what you see with transplant survival in people with age 65 or greater at the time they go to transplant. So this shows the Kaplan-Meier curve, and if you want to see more, Kevin Robinson's presenting this on poster 631. Is it a great outcome? Is it perfect? By no means, no. But we have folks with sinusopacia transplanted at our center who are now 10, 15 years out from transplant with good quality of life. It's not for everybody, but it is an option. So making referrals early and finding that the local transplant center won't allow that also potentially allows for second opinions. So people can see and seek an opinion from another center and try and gain access if that's something that they want. So Trikafta has done a wonderful job in reducing the need for transplant. You've all seen this slide. There's one more recent look from Miriam Valapor's group published in 2025. It shows the number of transplants across the country, all the way to over 3,000 in 2023. But the number for CF is a minuscule fraction of that, thanks to modulators. What has this done? In many ways, it's created a population of people who are living longer with advanced lung disease. And it's nice to think about what are the characteristics of those people who go to transplant in the more modern era. So this is from registry data. These are transplants performed in 2021 to 2023, 113 individuals. Note that there's a pretty wide variety of lung function there, all the way from less than 20% predicted to greater than 41% predicted. So these decisions on listings are made carefully. They have to incorporate patient goals and preferences, input from the CF team on disease trajectory and prognosis, and input from the lung transplant team on risk and benefit. I'm going to not go through the disease considerations for sake of time. Shift gear for a minute on consortia, since that's one of the things we want to talk about today. We think about post-transplant phases and complications. This is sort of the course after lung transplant. Get surgery, go through several months of recovery to a stable period, a little bit of a honeymoon for many people, and then this long term, which hopefully is still a honeymoon, but can sometimes not be that. And these landmines exist along the way, but the big landmine at the end is chronic lung allograft dysfunction. That's the major cause of death in long-term survivors. So the Cystic Fibrosis Foundation is supporting a wonderful consortium that was established in 2017. It's a biorepository and registry study. The aim of this study is to collect clinical information and human samples, blood, bronchoalveolar lavage, to be used for research studies related to lung transplantation and really focus on this problem of chronic lung allograft dysfunction. So the enrollment to date is now over 1,200 recipients. We're closed to new enrollees other than individuals with CF. We have a very robust number of people with CF in this registry, over 500, and the information that we have here with linkage to the CF patient registry will be invaluable in describing the natural history of lung transplant and identifying opportunities for improvement. These are the centers that are involved. I'll give you two examples of studies that have been done with these sorts of consortia. One was published by Todd in 2025. They used a separate data set, the CTOT20, and they basically said, what are the clinical factors that we collect that can be useful to predict long-term allograft dysfunction? And they identified these 5 factors among a multivariate analysis. And then more recently, there's an effort to look at the molecular signature of people who have chronic lung allograft dysfunction with the hope that this would be a useful biomarker. So you can do airway brushes in the lower lobe, as shown in the radiograph on the left. And then John Greenland and John McDyer in San Francisco and Pittsburgh put together 2 cohorts and developed a score that they call the Airway Inflammation 2 score. And what you see, without going into details, is that those with a high score, a high tertile score, had much lower retransplant-free survival in both the UCSF cohort and the Pittsburgh cohort. So now they're going forward with collection from multiple sites to try and identify in a larger cohort, would this be a useful prognostic tool so we can identify those who are at high risk and tailor their immunosuppression such that we can improve their outcomes. So in summary, I think it's safe to say that the modulators have changed the trajectory of disease in people with CF and advanced lung disease, but the risk of shortened survival remains high. And I'd like to submit that we need to remain very focused on this group so that we can do better. The registry will provide additional insight and potentially better predictive models for survival. The lung transplant journey is a hard one. The discussions are hard, but referral remains important and is an opportunity to make sure no one gets left behind. That's always been one of the goals I think we have as clinicians and care providers. We can use the available guidelines and tools, the learning network resources to try and do better. And then the lung transplant registry, I think, is really going to hopefully transform the way we take care of transplant recipients and improve their long-term outcome. So thanks for the opportunity. Happy to take any questions. And before you start that, I have a few people I want to acknowledge on this slide. The folks at the CF Foundation I have a privilege to work with, the people in our team, Kevin Robinson, Mike Meyerberg, and people in Pittsburgh. The principal investigators of these 15 sites have been fabulous. We were worried that we'd be able to work together. It's actually worked really well. I think Ramsey and John can comment on that. But the research coordinators and transfer recipients have been invaluable to this work. So thank you.
Right. Thank you. Oh,
Go.
We'll let the first question be from the microphone. Thanks, Kristen.
Joe, thank you so much, Chris Bend and Boston Children's. Very carefully worded and very well. I just want to add the pediatric part to this because you left this out. And we just, the ISHG, we've just published, the referral guidelines for pediatric lung transplant care the first time, just actually out in the journal, which is important. And it's even more difficult in pediatrics to predict. And you've shown the figures. I mean, there are hardly any. I think the last child that underwent lung transplantation for CF at Boston Children's happened in 2019, where I worked before in Zurich was 2018. So there's really not much around. But just for me, people to be aware, there are still children out there that do require at least an evaluation for lung transplant. And I think you said it, it's about, not just the patient, but it's the family and everyone in this decision process. It's much more difficult in pediatrics than it is in adults because you have a lot of players that, are important here. So I just want to get the message out there for all the centers, CF centers. Do not make this decision on your own. Refer early. This morning in the fellow session, there was a child with 4 years of age. She underwent already a lobectomy for hemoptysis. So, it's predictable that these things might not last for the next 15 years or so. So I think it's very important to get that message out.
Thank you, and sorry for the omission of the pediatric guidelines.
You only had 20 minutes, and Kathy gave you a hard task, and I know her. So.
Thanks very much, Christian.
I was going to say thank you for accomplishing the very hard task of covering
That's
so
okay.
much related to the consortium. Go ahead.
Yeah, this is fantastic. Thanks, Joe Elizabeth Dallin from UNC, also a pediatrician. So thanks, Chris, for adding that piece. I was just thinking about as the number of transplants for CF goes down and down and down, what are ways that we can ensure that our patients with CF who do undergo transplant at centers that are mostly transplant and other conditions are getting, the best possible care? And I'm just wondering about kind of enhanced partnerships with the CF care team. I know there's work already being done in that area, but some smaller lung transplant programs are now going to see almost nobody with CF, but still doing CF transplants.
We talk about it without a solution is the short answer. I think we're concerned that there will be sites, transplant centers where surgical experience wanes and the surgical complexity issues are significant. CF's different from every other disease, but most of the other diseases that we do transplants for. And then the supportive team around the surgical team, I worry a lot about that. In an ideal world, you would build a network of a small number of transplant centers, sort of like has been done in pediatric lung transplant. You only have, 7 sites, 8 sites across the country, not very many, because there isn't a high need. You would do the same thing for CF. The logistical challenges of insurance and travel and that are hard in pediatrics. They're probably even harder amongst adults who have jobs. I wish I had a great answer, but it's going to take a lot of education, and we're going to need to continue to keep our finger on that so that we can get the partnership, as you said. But at the institutional transplant team level, they're going to have some level of knowledge. It's hard to teach. A lot of it's experiential.
I have one other question. What's your approach at the University of Pittsburgh to ensuring that people will receive guideline consistent care? And do you have any tips or tricks that you might share with the audience for trying to make sure that these conversations and referrals actually happen?
So we have a pre-clinic huddle that our nurses do every week, and they will point out to us when people have had their last advanced lung disease testing. Echocardiogram, 6-minute walk. We don't do many blood gases. To be honest, we rely heavily on CO2 on the electrolyte panel, and if it's high, then we'll get a blood gas. What's worked best for us is having the nurses hold us accountable and keep track of it. We're going to build a better tracking tool when we go to a newer version of Epic that will have it on a spreadsheet for us buried within Epic. Right now, we're doing it sort of manually, so it's suboptimal, but it's a really important issue. I think we'd love to get more testing on these folks to know where their disease trajectory lies.
Thank you. Great. Thank you.
Our next speaker is Kristen Reichert. She is a professor at Johns Hopkins School of Medicine, and she's going to talk about adherence and the success with Therapies Research Consortium, or STRC.
All right, I'm going to stay on the presenter disclosure side for a little extra more time than most people because I have 2 more I have to put here. I'm such a science nerd that I forgot to put in some slides about what the STRC is. So you're going to have to just hear me talk about that a little bit. And with that, I also forgot my acknowledgement slides, which is awful because the STRC is just an amazing group of folks. So I co-chair the STRC with Greg Zawicki. Boston Children's Hospital is the study management core. Hopkins is the famous data core. Thanks, guys. We have, I always lose count of how many sites we have because some are peds and adult, but about 20 sites from across the country that are amazing. And most importantly, we have 5 current and 12 former community members, parents and adults with CF who have been formative here. And I will be highlighting that throughout because you can't not do it. But I will say that our integration of the community members is very well described in a 2023 paper that we published in Journal CF, and Felicia Reed gave a great talk yesterday morning on interviewing former steering committee members about what they got back from it, and it was so heartwarming. So I'm doing my acknowledgments now so I don't forget. Thank you to everybody on the STRC for being super amazing. So STRC focuses, I know the topic said adherence, but we did some strategic planning in the past year, and we are broadening or have broadened to be more self-management, which includes taking medications, but is so much more. It's anything that you need to do to take care of yourself and manage your health and your overall health. So it includes everything listed on here. So I, again, don't follow directions, I guess. And so I did sort of a bigger review of everything where STRC projects fit in there and where I think we need to go. So bear with me. I'll probably be slightly different than the other talks. But when you think about self-management and all people with CF need to do, you must start with treatment burden. So this figure is from a review paper this year that looked at all the different measures of how we measure treatment burden. And it's pretty sad state of affairs. So this was their conceptual model. The vast majority only look at the amount of time they do. And only the time, how many meds you're on or how long it takes to do the meds. So 100% forgets all the time I do on paperwork to get my prior authorizations. If I have CFRD, how much time does it take to get all my equipment together? So that is one downside. Many include psychosocial components, but almost fairly superficially because we try to keep our measures brief, and burden is so much more than that. And the only other study around treatment burden was one study in 2006 about out-of-pocket costs. So I'm going to say that might be a little outdated, and somebody needs to update it with the cost of modulators right now. So treatment burden, big issue. So STRC, led by Jennifer Butcher on this particular paper, in our partnership with the Simplify study, we did some qualitative interviews with about 100 folks and asked now that you're on ETI and you went through a study where we took something off your regimen for half of you, what does treatment burden mean? And so you can see that in theme 1, all the things, and it overlaps a lot with the other schematic. What I want to highlight is 2 areas that are previously, I think, unacknowledged in burden is the idea of sometimes I give up my sleep to do my care, or I prioritize my sleep over doing my care. And also social. I miss out on social events to take care of my health. I skip my care to be able to, have fun. And fun is very important. I'm not saying that in a negative way. And then, how did treatment burden change? And you can see it's everything. For some people, it increased. The stress of making sure they can still afford their medication added to their burden. Being able to take away Dornase and hypertonic saline, that was great, but there was still more. I now have to worry about weight management. So there was a lot. Most people said reduced treatment burden is awesome, but we should not assume that ETI has reduced burden for everyone. And then how are they managing it? I just want to highlight 2. Some folks, and clinicians know this, some folks are coming in already saying, how can I simplify? Can I stop taking Dornase? And some just do it on their own. And I think that's a really important thing we really need to think about as we're trying to measure. But I think the big takeaway from the review paper that I mentioned before was our measures are just not sufficient. We don't have a great way to measure burden, even though it's the number one thing that people with CF and their families would like to manage. So I wanted to bring up the daily care check-in, not because it was made as a burden tool. It was made as a barrier to therapy. So still only focusing on taking therapies, which is a teeny tiny part of self-management. But it does cover these other things. It talks about how much time do you have to spend. I missed therapies because I had to manage all this paperwork and it was delayed. And so I missed getting a refill. But what I really like about this measure that we created is we asked, did it happen? And then how much does it interfere? So it makes it easier to say I had a problem, right? But it also helps you clinically say, where do we want to focus? So we validated this in the traditional PRO kind of way, and it goes with everything we think it should in terms of a total score. But we worked with the CFLN on a mini little iLab to use this in clinical care. How can we do this to promote conversations around challenges? And our thought was have somebody fill it out and then co-produce, what do you want to start with? And so one example, this one, which again, I know you can't read, but the question is, did you skip a treatment because you didn't want to do it in front of another person or in a certain place? So that stigma, the embarrassment, if they mark yes and they say it sometimes, it's a great way to open up that conversation of what can we do to help that? Can I help problem solve? Care teams have heard a lot of great strategies that can we maybe help share those. So I think we need better measures of burden. We need to stop just saying burden is terrible. We do need to start intervening. And I think this is a great way that we can start doing that clinically, but also have a research tool in some ways. So that's looking future. Adherence, I'm going to start with the not modulators. So I think we're all pretty aware adherence and even prescription of other pulmonary meds to manage CF symptoms is going way down. And we don't always know how that is coordinated. None of these studies, interestingly enough, gave their ETI adherence. And so it's great if we can take some of these meds off and reduce burden, but does ETI adherence have to be higher? So those are going down. What's happening with modulators? Review paper from 2024, ETI is still incredibly underrepresented in adherence research. Well, all modulators are. This is it since 2012. The ones with the arrows is one study of ETI that looked at, and there's one study, but the orange little diamonds are folks who got their pharmacy care through their clinic, and the purpley one circles are the ones that didn't, and you can see adherence starts going down when you don't get extra support. You can kind of see the time trend for all modulators goes down. That's what happens with all therapies. This is not unique. It's not different. But what I want to remind us is this study, which is one of my favorite studies because it actually looked at the importance of adherence. It's older and so technically not this year in review. But even with these tiny drop downs, they show that increasing non-adherence is associated with decreasing lung function. So we really do need to think about this. And since this was published, there's one other study, you can see small numbers, ETI medication refills starting to go down. STRC has the Yeti study, your ETI study, that does have pharmacy refill data. We're still putting that all together, so I didn't feel like I could give you really raw data. But yeah, adherence is fairly, it's not 30% like Dorney's adherence, but it's not 100%. So we really do still need to be thinking about it, even though it's just a pill. What's correlated with ETI adherence? We don't know very much, I gotta say. Yeti's gonna help. And there's our cute little mascot down there. We have some posters here showing that depressive symptoms are associated with ETI adherence, health beliefs are associated with ETI adherence, and these things are very important because they suggest areas that we can intervene to help support. More will be coming. We have relationships with the care team, trust in the care team. We have a lot of data that we're in the process of analyzing and preparing. So lots to look forward to. STRC right now has not done much with GI symptoms, but as we look into the literature, it's a future direction for us. It's amazing how little we know about self-management of GI. That just isn't out there. I think we were so focused on lungs, and now that maybe we can breathe a little, we can now focus also on other symptoms. GI symptoms are associated with mental health and quality of life in big ways. And this is, even though this is the current year, there's not much research. This was a study of 8 people looking at a whole food diet intervention, which had benefit for those who joined the study, but most people didn't want to join the study and do this food diet. And so we really do need to think of ways that, again, hopefully the TDN is working on a therapeutic answer, but in the meantime, we need to find a way to do some symptomatic management and help with the therapies that we have and support folks. So I think that's a really important future direction. STRC has also worked with the Strong CF group, which is about defining new outcomes for measuring nutrition beyond the BMI. When that study started, we looked at the literature to try and help them and realized there was no research on adults with CF and their thoughts about nutrition, like zero. So we did a qualitative study. Amanda Bruce and Deanna Nyarho led it. I will point out also with a parent of someone with CF as a co-investigator and a co-author on this paper. This is really important for us within CF. The first part was to define what does nutrition mean to people with CF. And you see that not on the slide because when I started making the slide, I was like, oh, they want healthy foods. It means fruits, vegetables. It no longer means to them I have to eat high fat, high salt. They're really looking for a high quality diet that is generally recommended. But when asked what helps you eat that kind of diet, what gets in the way of doing that, these are what was listed. And one point I really want to put, the care team is on both. And again, that's because we interviewed people from around the country, not from a single site. A big plus being able to do this is when you had a good dietitian, it was really, really helpful. When you didn't have a good dietitian or members on the care team that could give you useful information for you, not so helpful. I think, the importance of social support, someone who helps me make my food, someone who sits with me while I'm eating my food, not having symptoms, really important, and really thinking about the finance. Eating healthy is expensive. And so how do we help folks? I'm going to switch a little bit to remote monitoring and mHealth. We've been working in this realm for a little while now, and people with CF and healthcare providers like the idea of using technology, but the actual using it is really hard. And so these are just 3 studies that across the board just say, it's a lot of work. Where's the benefit? How are you using this to help my health, my betterment? Is it accurate? How much does it cost? And when I get bored with it, I'm probably going to stop using it. And so these are all things as we move towards telehealth, as we move towards more remote, trying to capture some data in research studies even. How are we going to support that? And I think we all have our stories of the pandemic where everybody pushed out home spirometry to folks, and nobody used it. So this is a study from Sweden that just really highlights this. They asked folks to use their home spirometry once a month. And over almost a 2.5-year period, 29% never used it. And as you can see, even by 150 days out during the pandemic, only 7% made that threshold. So they were like, well, let's see what happens if we go 2 months. Let's see what happens if we go 3 months. And it just drops off. And so why is that? It's hard to do. It's, what's the value? I'm anxious about that number. So I think these are things that, again, would be great to have so they can identify when they need to come in for care. But if we're not using it, this is a great behavioral opportunity. These are things the STRC is interested in, not just from a research perspective, but how to support clinical care. Apps, everybody loves apps until they hate them. I'm going to use the Genia app as an example because they published a study with beautiful fun data that makes the point. But all apps have the same issue. So the Genia app is patients can self-monitor their symptoms and then make a little report that they can share with their care team to co-produce their healthcare and make decisions. And what they found was, and this was in Sweden, all the centers in Sweden were asked to do it, a high adopter site. I'm going to orient you. The blue line is 50% of the clinic used it in that month. The green line is only 20% used it in that month. And this is an example of a high user site. And they did some qualitative work about what made a high use site. The clinical team and the patient population valued patient-provided data. They had a person-centric clinic, and they had a really good plan on how they were going to use this data. But the medium use, you can see the shift because I put those lines there because you can see the axes shifted. They never got past 50%. They felt like they were selling a commercial app. I can tell you, Genia app was made by a parent who has 2 kids with CF, and I can guarantee you he's making no money off of this. So it's not even commercial, but there was just that sense, right? Like the validity and integrity, the credible nature of the source. These sites found it really hard to integrate into their workflow, and they relied heavily on just that single champion. So we talk about needing a champion, but the champion can't be the be-all, end-all. And so you can see, like, where COVID-19 pops in, that person the resources got reprioritized. They couldn't focus on it, and their use of the app dropped way down. And then you have low functioning, low adoption sites where less than 20% use it. Again, don't want to sell it. They felt it was imposed on them. They were being told they had to use it versus I'm choosing to use it. This is all, behavior change of thinking how to do this. They're not interested, and they couldn't find a way to integrate it into their flow. And staff and patients, there was a sense of they used it early before it was fully fleshed out with all the features. And then they were like, I don't want to use it. It's underdeveloped. And so we have to really think about the right time to introduce. You don't want to wait for the perfect mHealth solution, but you also don't want to put out something that's half-baked. We are working with Upstream Dream, which made Genia, we developed an app with them to support modulator health, and adherence, with symptom monitoring focused all on behavior change techniques that are well validated in the literature. We did an extensive systematic review that got published. And it's called On Track CF. We're hopefully seconds away from being able to launch that. So I don't have data and I didn't want to show you screenshots because we're still really in that development phase, but that is one of the STRC moving forward initiatives. I think this is a great study on how to use data, right? One of the big things is we couldn't figure out how to put data into the clinical flow. So this is the group out of the UK, the Pluto group. And they have for years had this learning health network, CF Health Hub, where they developed an adherence program, and they wanted to figure out how to put it into use. And so they took FEV1s, and if they and BMI, and if either was going down, they were going to look at modulator adherence. They have access to pharmacy refill records, just like most of us do in their EMR. If it was unsatisfactory, they'd refer the patient over to this well-established, published habit formation intervention. If modulator adherence was fine, but lung function was still poor, they moved into their nebulizer adherence where they had objective data and did nebulizer. So there was just this algorithm. So I think it's much like, quality improvement at the site side. There's implementation science thinking through what are your processes, and behavioral health folks can help with that, thinking that through. But we also need to think about it as we're developing our interventions. We can't make things that are difficult. So one of the STRC big issues is our initiatives and values is how do we make it practical and implementable. The other thing I want to say is that the STRC has now, there's been many publications now around aging, the health implications of aging. They superficially touch on the self-management implications of aging. So we have a writing group that is going to be pulling together a manuscript around self-management implications. And these are many. You have your daily care, but as you're aging, you're having more comorbidities that you have to manage and figure out how to manage them integrated. You have general health issues. As we get older, our sleep gets a little messed up, at least for me. And then attending medical appointments and more medical appointments. There's much more health screening, right? Like a lot of the medical data coming out is that folks are getting hypertension, et cetera, cancers earlier. And so we have to do screening earlier. And so that is just more burden that comes on. And how do we get people to show up for all their screenings? We know from OGTT that's really hard, but it's going to become harder as they're older. Healthcare access. How do you maintain insurance? What is Medicare going to look like as we have more people with CF on Medicare? How are they going to pay for visits? How close do you need to live to the medical expertise you need? As people become older, they don't like to drive too far, and many of our patients drive really far. And so are they not going to come to CF care because it's just too much of a hassle? And then there's also just general life planning. We have many folks, right, who in their 30s were kind of told they weren't going to make it much longer than that. And so they planned very differently than for I might live to be 70 or 80 or 90. And how am I doing this? What's my retirement? What's my employment plan? Family planning clearly becomes an issue as you move into your 30s and caregiving. But I will also point out that many people with CF rely on their parents to help take care of them. And as their parents become 80 and they need somebody to take care of them, now you're sandwiched in taking care of yourself, taking care of your parents who used to be your caregiver, and maybe having kids, right? Because yay, we're having kids. And so they are totally sandwiched and stressed and overwhelmed. And so how can we help folks? And so this is my last slide. What do we need? So I always am somebody looking forward, and I think these are really important things that we need to be working on. How do we measure burden? But more importantly, how do we intervene? What are the implications of lower modulator adherence? For whom needs to still stay? Who still needs to stay on the other pulmonary meds? Either because ETI adherence is a little harder or just because that's their where they are in their illness. What factors can we modify? How can we use mHealth and remote monitoring to support that in a very positive way, not a punitive way? Nutrition, CFRD, GI symptoms, all ripe for some good self-management interventions. There are plenty models we can use from chronic diseases, bring it over and start maybe a little ahead of the curve. Promise of remote monitoring, but we got to figure out a way to make it easier for everybody. And aging with CF is going to be a huge deal. So that's about all I have to say. A lot.
So I'll start us off. I think it's very easy for us in the clinics to get caught up in the physical health and the FEV1 and the things that are right in front of you. And it's much more difficult to ask about treatment burden and collect that data, which probably impacts our ability to address those and improve adherence and things like that. Do you have any tips or tricks or things you've learned through review of the data and your participation in the STRC that might help?
Well, I think that's in part why we made the daily care check-in. Because that's an opportunity. It can be, again, easily done in a screener, because I say that farcically because we know that's hard. To just, can we get there and can we look through it and pick out the one or two things that someone wants to work on? Because it is, during the iLab, it was impressive what people said and what they acknowledged. I remember Chris Saracusa coming up and being like, we used it with this person we couldn't figure out at all. And she answered all these things. I had the best conversation I've ever had with her. And we were able to identify things that we could do differently to support her. And that's exactly what it's intended for. And I think those are ways we can start having that conversation, without making a ton of work. I mean, you can't, if the average number of barriers people endorsed was 7. So that's a lot. But they didn't say all of them interfered a lot. And so do we want to start on the easy ones? Do we want to start on the harder ones? We co-produce that conversation then. And so can we get a little data before you walk in the room so you know what to expect?
How often did they administer that during that?
Because it was just a 6-month iLab. It was only once.
Okay.
I mean, we're thinking it potentially once a year. More. It's sort of like mental health screening would be my idea of at least once a year. Make sure things are okay. If there's big issues, it's something that you put on the problem list in a way and revisit.
That's really great. And you covered so much data. Everyone got the assignment today for how much to cover in their talk. It's a lot. Thinking about your experience in STRC, can you give us an example of a time when your community partnership involving a community member in the process sort of changed your direction or helped? I know I didn't give her this question.
I mean, that could be a whole talk. No, my face is not, I can't have it. I have too many examples. I'm trying to figure out which one to start with. I will say we've had community members from the very beginning, and it became very apparent the very first research meeting we ever had where the person said, I will not be in this study. And we said, wait, what? Why? And we were doing nebulizers. We were giving everybody eRapid so we could track their adherence. And they have the handsets. Those handsets break easily. And she said, well, you're only going to give me one handset. What if it breaks? I don't want to mess up your data. I don't want to have that stress. And we're like, how many do you need? 3 would be good. Well, they cost $20. Like that research cost is nothing. So we have that. We have one mom who has been first author on 2 papers, who has experience with qualitative research, and she just brought such a richness and depth of thinking about things that our papers are infinitely better because of it.
Those are great examples. We'll do one quick question.
Thank you. This was a fabulous talk. I'm going to pick the easy part, the aging with CF. How, as the requirements to be adherent expand, are there strategies on how you identify what is a priority when everything seems important?
That is where co-production of care, I think, becomes really, really key, right? I think there are some things. Crisis, you take care of crisis first. But after that, it's where do you want to start? I think that's true for all of us with lifestyle behavior, obesity, and anything. You know, I have colleagues who are geriatricians, like they're used to this multiple comorbidity. Where are you willing to start? Because I may want to work on my diabetes and not my GI symptoms. I may want to work on my mental health and hope that there's a lot of evidence starting to show that getting your mental health and your sleep straight helps you manage the rest of your illnesses. And so really, where do they want to start is the most important thing. I mean, clinician opinion is important too, but I think if we fully dictate, we go in this order every time, without talking about it, they're like, you're just talking. I don't want to come back. And so again, just PEP skills, really important. Where do you want to start? Let's set our agenda together. These are the issues. This is what I'm worried about. What are you worried about? Where should we start?
That's great. Thank you. All right. So our last speakers for the day are Doctors Dio Cavallera-Rotos. Cavallera-Rotos, and Dr. Elizabeth Dellon. Dio is an associate professor at Emory, and Dr. Dellon is a professor of pediatrics at UNC Chapel Hill, and they are the co-chairs. We're the co-chairs of the recent pain guidelines, and they are going to talk today about that. Oh, hold on. That's the wrong file. We've got it. Here you go. Thank you.
Thank you so much for having us. Thanks for the invitation, and thanks to everybody for staying and for staying awake. Hopefully we'll keep you awake for the rest of today's talk. So like everybody else, we've got a tall order. We'll be covering a fair bit of work that we've been doing since 2022, 2023, working on these pain guidelines. So what we'll be doing is taking you through, actually, we have no relevant disclosures to this presentation, but what we'll be doing for the rest of today's session is really walking you through the entire process, right? So some of our formative work that prompted us to the urgency for the need for pain management guidelines in CF, then talking a little bit about the data that informed the guidelines that were published earlier this year. And then we'll close out by summarizing a bit of keeping it current, some ongoing and recent research regarding pain in CF, just to give a landscape for what is actually going on and what's in the horizon. One point that I wanted to point out before we get going is we did have a community member who was going to be with us today, Cade Hovater, who is not able to be here with us, but really important that he is highlighted through this because he's been a really important part of this work over these years. All right, so turning over to Elizabeth to get us started with some epi work.
Great. So I think we're all well aware that pain is common among people living with CF and really throughout the lifespan. In some just kind of pooled data from some small descriptive studies, and this was pre-modulator, pain was estimated to affect 42% of children and about 77% of adults. We know that pain can be acute, it can be chronic and more persistent, pervasive, and it can be related to medical procedures. So people with CF experience pain for a number of reasons, and it is impactful. This is, again, sort of pulling from small studies, but we know that pain is associated with poor physical functioning, increased frequency of pulmonary exacerbations, impairment of sleep, emotional symptoms, impairment of work-related tasks, decreased adherence with therapies, reduction in overall quality of life, and actually reduction in survival. And I think many of us might wonder, how much of this pain is related to CF and what are other causes of pain? Pain is common in a number of conditions. Sarah Allgood's study that's highlighted here asked people with CF, do you think your pain is related? And 70% said that all of their pain was related to CF. And actually 85+% of people said they experienced pain of some sort daily. 70% said that their daily life was affected, and 75% said their mood was affected. So this is from the perspective of people who really feel it's specific to CF. This is just a quick little look at not at all exhaustive list of the ways that pain comes to people with CF, right? It's a multi-system disease. There are many reasons that people might develop pain related to CF. Many of them overlap. Multi-system pain is also common, as it is in many other chronic conditions where people experience pain in multiple locations of multiple types, and it can be difficult to kind of tease out, the best approach to treating that. We know that pain is under-recognized in CF, and these data are from a CF Foundation sponsored or supported survey that was conducted after availability of ETI about pain in people with CF. And we surveyed adults living with CF, caregivers of people with CF, and CF clinicians, asked them to identify symptoms that are experienced by people with CF. And here you can see that pain was the most common symptom reported by adults with CF. But caregivers and clinicians both reported cough as the most common symptom. Pain was third most common reported by caregivers, but it was not even in the top 10 reported by clinicians. So clearly a disconnect here. Additionally, the impact of pain is underappreciated. So pain was also the most distressing symptom, and distress, right, being a tough word to completely define, but that was the word that we used. That was the most distressing symptom reported by adults with CF. Caregivers and clinicians did identify that pain was a distressing symptom, but clinicians thought it was number 6 in order of the symptoms that were represented. And so again, a disconnect here. Also from this survey, I think highlights that pain is really undermanaged. 3/4 reported experiencing pain, and there wasn't any difference between those taking or not taking a CFTR modulator. There was a difference in reported level of distress related to pain, though, 64% overall, but more pain-related distress in those not taking CFTR modulators. And people identified a number of concerns about pain management. So 59% said that CF care team manages pain not well or not at all. People felt that the complexity of pain in CF is often overlooked by clinicians, and people felt that they were fearful of some of the stigma associated with pain, right? So being labeled an addict or a drug seeker, things related to side effects of pain management, things about just sort of someone who identifies as living with pain and associated stigma. And people highlighted some needs related to pain management. So people with CF identified wanting multimodal approaches. We don't just want medication. We want to know what else can help. And also, importantly, a desire to maintain a level of function and have ongoing treatment options with disease progression. So I'm going to step aside and let Dio highlight some work that is adjacent to our guidelines that I think is really, really key for us to know.
Yeah. So supplementing some of the epi and formative work that Elizabeth just talked about, getting us to the point of creating guidelines, one thing that was really important to us was centering the voices of people that whose lives we were hoping to affect and improve. And so throughout the entire process, we had a really strong patient and family member representation in the guideline creation process. What I'm showing here is a screenshot from a paper that was a companion piece that was written by 2 individuals that were on our guidelines committee and another individual who's been very active in CFF. And really, it was important for us to have a companion piece to humanize the guidelines that were coming out, to really put a face with these and put lived experiences with them. So this was a paper that the 3 of them wrote with the assistance of a medical editor that accompanied our guidelines. And I pulled out one quote that I think centers a lot of this. So, quote, "Living with CF means managing not only our symptoms, but how other people perceive them. All of us have come to understand that our pain makes others uncomfortable, so we tend to mask how we feel. Maybe it's because it's so normal for us to hide our pain, people don't always believe how truly bad it is, including sometimes our own care teams. In fairness, we don't always recognize that pain is abnormal or optional. No one tells a 6th grader to expect arthritis or what it feels like. And because we have heard the message our whole lives that pain is a part of CF, we often believe it and endure the struggle." So as we think about the guidelines that our team put together that Elizabeth is going to go through in detail now, I'd like for us to keep in mind where this came from and how important this is to those who we serve.
So tackling the problem, right? So we know that there are some papers out there, and then there's a lot of clinical experience with pain, right? There's not a lot of research behind this, and Dio's going to talk a little bit later about ongoing things. So not unlike some other aspects of CF care, right? We went to clinical practice guidelines before we had a lot of research to inform it, because it's a priority. People identify it as really, really critical. So we had an international group of people, including 3 community representatives, 2 of the folks that you saw in the picture, and then a parent of a child with CF, to come together to review the literature on assessment of pain management, and communication about pain between clinicians and CF care team members and people living with CF. We wanted this to be rooted in a sort of guiding principle, something that could really bring us back to why we're doing this and what are some of the important things that we need to keep in mind. And so by consensus, we developed this principle that treatment of pain, of any pain in CF, whether acute, chronic, or procedural, requires a co-developed plan with these components, a multimodal approach, age and developmentally appropriate assessment interventions, right, because pain occurs throughout the lifespan. Of course, concurrent treatment of underlying causes and contributors. Consideration of societal stigma of the pain experience. Again, this could be a session in itself. And then sensitivity to regional access and financial burden, right? Because we know not everybody has the same access to different types of therapies, especially if we're thinking about multimodal management. So this is just a screenshot, and I wish we could go through these in detail. Time won't allow, but we're going to at least gloss through what we are recommending. And again, I just want to highlight this is an international effort. Our community representatives not only shared their stories and contributed lots of amazing ideas, but also review the literature. I mean, these people are unbelievable and wonderful, and we're so grateful. So we came up with both some general recommendations and then also some more specific when there was enough evidence in CF specifically. When there was not, I'll tell you a little bit more about what we did. But for kind of our general recommendations, we really just thought about sort of practical things and looked at general guidelines for pain. So our recommendations here were that CF care team members receive education on pain assessment, management, and communication. We have a table in the paper that outlines a lot of resources and lots of different formats. So we hope you'll check those out. We also recommend routine screening for pain in people living with CF using age and developmentally appropriate assessment tools. I'm going to show you what those are. There was an exhaustive search of available tools, and the idea of pain being multidimensional really guided needing kind of at our entry point, screening both for the intensity of pain and also pain interference. So what is the distress level? How does pain get in the way of your activities? And we made recommendations for both non-procedural pain, so acute or chronic, by age, and then also procedural pain. And so that, again, is outlined in our guideline. The screening ideally is occurring at every clinical encounter, certainly during hospitalizations as well, and then, of course, around procedures. Going down to our third recommendation, this was then if people screen positive for pain and or pain interference, that we would conduct a comprehensive clinical assessment to evaluate needs. We also have a table adapted from Improving Life with CF that was a project, primary palliative care intervention study done by Anna Georgopoulos and Laura Dinger and others. And they outlined some really nice approaches to assessing pain. Supportive communication and thoughtful collaboration between the CF care team and people living with CF is another general recommendation. We also recommended assessing and addressing co-occurring psychosocial and mental health concerns, recognizing there's bidirectional relationship between pain and depression, pain and anxiety, pain and sleep disturbance. Very important to do this. Our sixth recommendation was that the primary assessment, management, and of pain and coordination around pain management occur by the CF care team, right? We are a medical home for people living with CF, and we have a multidisciplinary team, so we have a lot of opportunities to do this. And then finally, our last general recommendation was that when referral is needed, because it's beyond the expertise of the CF care team, we make that referral and we serve as historians and we coordinate care and ideally facilitate seamless transfer, coordination, communication. So this is just one of the tables that it would sort of give ideas about what might lead you to refer. So in the left-hand column, it's sort of indications or approaches to therapies that might be beneficial. So pharmacotherapy that might be beyond the scope or comfort level of the CF care team. We have an extensive table with pharmacologic treatment options and includes thoughts about when we might actually ask for expert opinion if we don't have a comfort level as CF care team members. We also address opioid use as another treatment modality for pain. Rehabilitative therapies, right? Bringing in our therapists who do incredible work, especially with musculoskeletal pain. We talk about procedures to manage pain, particularly around acute chest pain or lung transplant related pain management. Psychological interventions, again, super important, and also integrative medicine therapies. When people have access to these therapies, of course, they can be incredibly beneficial. So this is just sort of an example of kind of to whom we might refer and why. We also were able to make some specific treatment recommendations for people living with CF who experience musculoskeletal pain, acute chest pain, subacute and chronic chest pain, pain with procedures. Sorry, there's extra stuff on there. I don't know where that came from. And also lung transplant. And I'm not going to go through those specific details, but just know that there was enough, we felt, evidence to make specific recommendations. But evidence is lacking for a lot of pain sources, locations, types. And so when there wasn't CF-specific evidence for things like multisystem pain, sinus pain, headache, GI pain, or arthropathy, the recommendation is to create patient-centered treatment plans that are created in accordance with the guiding principles and adapting strategies for non-CF populations. Always thinking about unique needs, medication toxicities, things like that. So hopefully some helpful guidance there as well. And I'm going to turn it back to Dio.
So like Elizabeth just mentioned, there still are some pockets within CF care that we don't have strong evidence for. So just to leave us on a positive note, I wanted to sort of share some recent and ongoing research that's happening in the pain space in CF, just to give us a flavor of what's to come. So the first two studies that I'll talk about are describing models of care and thinking about how do we support patients with symptom burden in CF. So one is the Inspire CF trial that was funded by the CF Foundation, that is currently wrapping up right now. This is an intervention that was a 5-site, 2-arm RCT comparing usual CF care versus usual CF care plus the integration of a palliative care specialist on the outpatient side over the course of a year. The key domains in the intervention were physical and emotional symptoms, coping, support, and advanced care planning. The interventionists that were in the trial were physicians or nurse practitioners who received about 10 or so hours of training, including standardized patient role plays and advanced communication training. The primary outcome of the trial was quality of life at 12 months, and you can see a number of secondary outcomes here. Like I mentioned, the trial is still in the final analysis phase, so I don't have results to provide today. But this is, again, testing one model of care and thinking about how do we support patients with symptom burden in CF. The other that Elizabeth just mentioned briefly is the Improving Life with CF intervention. This was also funded by the CF Foundation. So this is taking a little bit of a different approach of primary palliative care intervention, really thinking about how do we equip and empower CF care teams to provide that first layer of palliative support to people with CF. This is a little bit different. It was a single-arm implementation trial, so really thinking about how do we implement these toolkits and what are the barriers and facilitators to sites taking them up. You can see here some of the components of the intervention, an annual palliative care screening, which came out of our 2022 CFF Models of Palliative Care Guidelines, and a number of other toolkits and supports for teams to implement that primary palliative care culture and process within their teams. And their primary outcome, again, because this was an implementation-focused study, is really looking at the percent of patients who were eligible who received an annual palliative care screening, which would incorporate things like pain and other symptoms. I'll point you all to this website that has a whole host of tools and toolkits that team beautifully put together with support from CFF. For anyone that's interested in implementing that primary palliative care focus within their clinics, this is a wonderful resource to point to. Another intervention that is currently underway is a CF-specific CBT for pain management intervention. This is also being done by the MGH team, an N of 20 feasibility trial looking at a 3-session mind-body intervention that incorporates CBT. This is it's designed to be delivered by the CF care team either in person or via telehealth. So really one of the first pain-focused CF interventions that we've seen out here. And the primary outcomes here, again, feasibility, acceptability. So really sort of the first kind of study, or the first implementation of such a study. And then the last is taking a little bit of a different approach. This is the Pulse CF study. This is a five-year prospective cohort study that's funded by the NHLBI. So really, this study is taking a whole person approach, taking a lot of the formative work that we learned in the process of building out these guidelines for pain, really thinking about the whole person experience of pain and other symptoms in CF. So what the study does, there's a lot of fancy words here, but what we're doing is we are prospectively enrolling individuals, adults with CF, for a year-long experience, where over time they are providing 3 biological samples of exhaled breath condensate and plasma. They're also doing 5 patient-reported outcome collection time points, looking at things like symptoms, quality of life, experiences with care and satisfaction with care, and a whole host of other outcomes. And then at the end of the year, we do a very extensive qualitative interview with them to understand their care and their care experiences, really pulling in the idea of symptom clusters. Does pain cluster with other symptoms? And then does the cluster of symptoms that you have, is that associated with the type of care that you receive, and the quality of care that you experience? So just a smattering of some studies that are coming down the pike. Like I mentioned, some of those studies are looking at models of care and how do we sort of restructure the care system and the care environment for people to be, to pick up on more symptoms and symptom experiences. And then other studies that are more qualitatively looking at the whole person experience. So in looking at the research landscape, I wanted to offer some research gaps and potential for future directions. If any of your mentees are watching this, maybe they've got some ideas here to help get some research kickstarted. So we really don't have as much research in thinking about mechanisms of pain in CF, and that is an underexplored area. As well, we struggle a bit with CF-specific pain instruments and other PROs that are relevant to people with CF. As well, this is coming out of the Pulse CF study, but really thinking about symptom clusters and identifying who are patients who are experiencing certain symptoms and symptom clusters, and can we better predict who those patients will be to better support them. And then, as Elizabeth mentioned, we still have some treatment gaps for different types of pain. Multi-site pain and sinus pain are 2 that come to mind first. And then again, I would also argue that we still have work to do to think about how do we restructure care models to better integrate pain assessment and pain management in a longitudinal and supportive way. So just to wrap us up here in terms of key points from today, we hope you've taken away that pain is prevalent and burdensome. It's still under-recognized and under-managed in CF. We hear this from community members time and time again. As well, from our formative work, we have evidence that people are afraid of stigma and fear about coming forth with their pain and their struggles with pain management. And so we should be sensitive of that as we reach out and care for these individuals. Pain assessment and pain management should be integrated within usual CF care, with CF care teams being the hub and referring to specialists as needed. So that's a nod to some of the work that we've seen in models of care, both primary palliative care, primary pain management, as well as the integration of specialists, whether those are palliative care specialists or pain management specialists or others who are associated with pain management. And then, as Elizabeth mentioned, and a nod to our guiding principles in the pain management guidelines, pain management should be multimodal, should incorporate co-occurring symptoms, and should be tailored to the individual, looking both at lifespan or stage of life as well as prior experiences. And then, as I just mentioned, we still have some work to do in terms of research understanding mechanisms of pain, as well as, again, those care models. So as we wrap this up, I'd like to point you all to, again, the guidelines or the recommendations that were published earlier this year, as well as many of the other formative papers that came out that informed those guidelines. And again, just another nod to that patient companion piece that supplemented our guidelines work, really giving a human voice to the work that we did over the past 3-4 years. Mm-hmm. And again, a nod here to the team that put this all together. This is a 23-person interdisciplinary team that we would not be here without. So a huge thank you to those individuals for their committed support over the years. And a huge thanks to the CFF for supporting this work.
Thank you very much for your comprehensive overview of the guidelines, and also, provoking some thoughts in my mind about me and my clinical experience. And I wanted to start, I'm going to ask a quick question and then go to Theda at the microphone. So I think that there's hesitancy in clinic to ask about pain. I'm going to say, because I
Go up to
I
the,
want to look at you, but I want to get the mic too.
not much space.
I think there's hesitancy to ask about pain because of a resistance to prescribing opiates, given the risks of addiction and really the potential bad effects of prescribing opiates, and there's no easy solution. And so I guess as the pulmonologist, maybe identifying the pain is maybe even a good first step. And then do you have suggestions for integrating the social worker and or mental health coordinator in the team versus when to refer to a pain specialist, which is not always available anyway?
Yeah, I think, that is one of the things that happens to us as clinicians, right, is that we hear pain and we think medication. And then we're like, oh gosh, opioids, no, can't do that, right? And we've talked about opioids in multiple, guidelines groups thinking about kind of indications in CF, knowing that there is an opioid epidemic and there's a lot of worry societally about opioid use, but also in CF, there are some specific concerns about side effects that might be more difficult to manage. And so we face it with a lot of desire to avoid, which is appropriate, right? We want to be looking first at what else can we be doing. And so I think that's where that comprehensive assessment comes in. And, as Dio was talking about kind of clusters of symptoms, co-occurring symptoms, almost always that is the case, especially as pain becomes more chronic. So doing a comprehensive assessment, really relying on our expert, team members, right? We have social workers, we have dietitians, we have, respiratory therapists. We have lots of people who can ask questions relevant to their discipline and come together and think about an approach, and bringing in maybe a pain specialist, but it might be that we have a lot of things that we can do before we get there. Also, not always available. When do we bring in palliative care? Well, certainly if pain management is complex, but also maybe if there are other aspects of, domains of palliative care that could be addressed by a specialist, we can think about that. So I think it's really so individualized. And we had a course a couple days ago on pain and presented a case that I think, it could be any of our beloved patients, but just really teasing out what was going on with that person and recognizing there are lots of things that we could be trying that we don't always think about. Yeah.
That's really great. Thank you.
Hi, I'm Theta Ong from Seattle Children's. Really appreciate your talk. Had me reflecting a lot on the number of journeys I've walked with patients who have really struggled with pain. And so I applaud having guidelines suddenly to help fill this void of how we even approach this. I have both a comment and a question. The first one is that I just want to recognize I have learned so much from having a child life specialist on our teams in pediatrics for managing even our frequent blood draws, for example. And there's so many techniques that are coming to light now that we are incorporating in our daily practice. And so I know that they are getting together here, but I would encourage all teams to recognize there's tools like distracting, where we do virtual reality headsets when we're doing blood draws, or we have these like what's called Buzzy Bee or shot blockers, or all kinds of things that we're bringing into practice as part of regular day so that it can take away this idea of you're feeling this pain, but how do we bring those in? And that's just, those are things we can generalize, I think, to broader and broader groups before needing those elements of additional specialists, right? People on our team and that are helping us in this work. The question I have for you is, I think there's well-established evidence that perception of pain, people are treated differently based on how they appear. So there's a lot of well-known systemic disparities in relation to that recognition of pain. And I'm wondering how the guidelines address some of those issues. Thanks.
Yeah, no, absolutely. And I think that we had a lot of conversations about this as a group. And I think there probably needs to be an additional comprehensive statement about this, right? But we sort of developed the guiding principles that we managed, or that we mentioned earlier. I'll just go back to, if I can find that, as a way to kind of, anchor this work in the reason that it's needed, wanting to really listen to what people's experiences have been. And, stigma and bias, came up over and over. There are a lot of good resources out there. Some of them are in our educational kind of references. A lot of it really is just kind of as you would approach any thing in patient care, like trying to check your own bias as you go in, trying to talk openly as a team about, how are we going to manage this in a way that really respects and honors this person's experience, and try to cut through some of the challenges that they've faced. But it's, this is the soul searching that we all have to do every day. But there are some really good references in there, in our education materials related to that. I wish we'd been able to give it an awful lot more attention than we could in the guidelines.
Thank you. So we have the time to have questions to everyone who presented earlier. And I guess the one thing that I feel like we could maybe talk a little bit more is the guidelines process. Most of the individuals who presented today have had some experience with or exposure to the CFF consensus document writing, and just wanted to hear your perspectives on how involved is the CFF, how are guidelines, that process of bringing together experts in the room, and how the patient participation really can shape the guideline process as well. So maybe since you're here and near a microphone, you could start.
Speakers up here because you've all been involved in guidelines work and consensus statements and things like that.
We'll just do 5 minutes. Come on.
Yeah. Do you want to kick us off?
Kathy, your question was multifactorial, right? There's so many ways we can take that, but I guess I'll take the community involvement angle. That's been a game changer for us. I think, Kristen talked about it in her work and her team's work, but really it has been our North Star from the get-go. I'll give a little bit of a sidebar. So when we were actually starting the pain guidelines, we actually had a taller order that we were going to do an entire guideline on all symptoms in CF. Kind of ridiculous. But what we did was we actually thought, okay, let's go to the community, and we used community voice to do that survey that Elizabeth presented. That was community involvement, right? And then we took it back to our stakeholder group and look to see what was the priority area, and that's how we landed on pain. And then throughout the entire process, it was our community partners and our patient and family stakeholders who really kept us honest through the entire experience and brought up things like pain, stigma, and bias, and their experiences with prior experiences with pain. And so I would just say that the mandate of having community involvement paid off in dividends in the process.
So I've been involved with some statements that were done by other pulmonary institutes, and they always mandated having a patient representative, and it was usually one person who was a high-level person in their own foundation, and they sort of sat in the back and didn't really participate. So I think one of the really key things is, one, to make sure there's more than one so that they feel like there's some strength in numbers. Like I mentioned, STRC steering committee has 5 that outnumbers the academics or matches the academics. And so that really makes it a more level field. But I think it's also hearing their voice equally is really, really an important part to ensuring that the voice and priorities are there, that they're not just there to rubber stamp and say, yes, that sounds good, or only find the really bad things.
I would just want to comment as I'm looking at Sarah Hempstead. I just wanted to give you a huge shout out as oh my God, but for all of the management of all of the guidelines, but in particular, I think the piece about community engagement, really helping think through, how should we approach asking people to be involved? And then how do we make sure that we involve and engage and welcome and encourage throughout the process? So Sarah, you've really knocked it out of the park with that. So thank you, all aspects, but that has been a really neat piece of it. So thank you.
Yeah, I was going to say the same thing about Sarah being an excellent resource. The CF Foundation does have a very structured approach, determining how many guidelines can come out in a year, which ones have the priority, which ones need to be revised, and then provides the support for the literature search and teaches the people on the committee, you need to ask the PICO questions and, know what you're addressing within the scope of your guideline. So I just wanted everyone in the audience who may not have had an experience with a guideline to realize that there's a real depth of expertise at the CFF to produce these documents, and there's so much support for it. And I've never done it through another organization, but I imagine this is a stellar example. Sorry if I stole what you were going to say.
No, I was just going to say a shout out to Sarah too, but I think that the choice of chairs is really important. All the guidelines committees guideline papers that I've been involved in have had just incredibly organized, focused, passionate chairs. And then enlisting the right people with a breadth of experience is really critical. And I think we've generally done that well with what we've done.
I think if I can add one more thing, it's to piggyback off of what Kristen said. It's also giving people the right roles and giving them roles that allow them to shine. We could have had patient stakeholders rubber stamping stuff, but we had them in the literature with us. We had them reviewing our statements. And that also came, at the expense of us teaching them the skills that they needed to be active, lay researchers in the process too. So that work was not at all wasted, right? It paid out in dividends in the process. But I think it's also us recognizing we have gems on our team and utilizing them effectively so that their voices can be amplified throughout the whole process. And then thinking about creative ways like having that companion piece to, again, humanize our guidelines was really important to us, and also gave a platform for our representatives to shine.
Well, I want to thank you all for the hard work you put into your presentations and for talking through the different, roles that you've had in this work, as well as all the fantastic support from the CF Foundation for these networks, consortia, guidelines process. And we're very fortunate to be in the CF community and to have your expertise in this session. So join me in thanking them.